Well, good morning, and welcome to the final session of the morning on the first day of this Tortoise COVID inquiry, though not the final session of the day. My name is Matt Dancona. I'm an editor at Tortoise, and this session will focus on, it'll be one of two sessions within the whole inquiry about the interior issues within the NHS. And the first focus will be in the next hour upon the questions of preparation and PPE and ventilators and so on. So the question really, I suppose, which we'll be trying to address is a paradox that I have been wrestling with myself, which is officially before the pandemic, one was always told that the UK was spectacularly well prepared for such events. We sent out experts to assist in Sierra Leone for Public Health England with the Ebola crisis in 2014. 2019, the Global Health Security Index said that Britain was the best prepared nation for pandemics. Pandemics were always at the top in recent years of the National Risk Register. And it was assumed, I think, that in political culture, in the mainstream, that we were in a pretty good space. So to put it bluntly, how come if we were so well prepared, we were so badly prepared? Now, that really will be, I guess, the objective of the next hour, to try and unpack that and get to some fairly forensic answers on why that was the case. Editing the chat will be my brilliant colleague, Luke Bedema. And we're going to move to a slightly different model of, before we get to our excellent range of expert witnesses, is instead of having a sort of adversarial model as we've had in the initial sessions, we're going to move to a more continental inquisitorial legal approach, which is to ask Tasneem Akunji, who's an extremely distinguished criminal defense solicitor, as it were, to frame in a prosecutorial and in a kind of forensic fashion the issue for us before we move on to asking the participants we brought along to give us some thoughts on their answers to the question. So Tasneem, can I ask you to kind of set the scene for us on this very important part of the whole pandemic issue?
Well, very, very grateful for the task of setting the scene, and I have been asked to be impartial. However, having reviewed quite a lot of the documents there, I think the facts will take you along a particular route. I'll try and be as impartial as possible. But in order to examine the propositions to whether a lack of personal protective equipment and panic at our health system being overwhelmed was in fact conducive to the first phase of frontline care decisions being made that were proper. To examine that, we need to look at what our government knew about pandemics, their threats that they posed, and the preparedness that was put in place before this particular panic hit. And in terms of how far back we can go, if we go back to David Cameron's government back in November 2015, he commissioned the National Security Strategy and Strategic Defence Review, which was basically a document that an examination of the main tier of threats the UK faced over the next 5 years would be. Unsurprisingly, the first one on that was terrorism. However, the fifth out of the sixth was disease, and particularly pandemic influenzas, which were identified as a tier 1 threat. The document went on to go, we have learned lessons from major incidents overseas. We have detailed, robust and comprehensive plans in place and the necessary capacity to deal with infectious diseases, including pandemic influenza and respiratory diseases. It went on to suggest that they will publish a biosecurity strategy in 2016. However, before that actually took place, the NHS, having identified that infectious disease was a tier 1 threat, engaged in what was called Operation Exercise Cygnus. Now, that was a 3-day exercise in October 2016, which was designed to effect a simulation exercise to see what the robustness or the rigor of our NHS would be to a hypothetical H2N2 influenza pandemic, rather similar to coronavirus. The exercise showed that the pandemic would, quote, cause the country's health system to collapse from a lack of resources. It also identified that logistically more health workers and resources such as ventilators particularly, and PPE, personal protective equipment, as well as hospital beds were required to face a large pandemic. The chief medical officer at the time, Sally Davies, stated that the lack of medical ventilators and the logistics of disposal of dead bodies were serious issues. Unfortunately, the results of SIGMAS remain classified at the moment, although there is legal action in progress to force the Department of Health to actually produce the report in full and its findings. But as of yet, that's not been the case. Following on from the SIGMAS exercise, that being in 2016, going on to 2017, NHS England then published an operational framework for managing the response to pandemic influenza. This is by Dr. Chloe Shelwood. She claims, and I quote from page 21, a number of stockpiles of clinical and non-clinical countermeasures have been established and are held in locations across the country for deployment when needed. The stockpiles are composed of pre-identified key items of PPE, including hygiene consumables, as well as clinical countermeasures. Many of the items are already in place in warehouses termed just-in-case stockpiles, while others will be procured through just-in-time contracts, i.e. they'll be ordered when needed. It goes on, though, to state that the bulk of stockpiles consisting of PPE are designed to protect healthcare workers from contracting pandemic influenza while caring for patients. This includes surgical face masks, FFP3 respirators, gloves, aprons, and hygiene consumables, very, very specifically mentioning the type of equipment that is already stockpiled, already in place, according to the document. Clearly, the operational framework document seems somewhat at odds with the findings that were disclosed of SIGMAS. However, moving on another year to July 2018, the UK Biological Security Strategy, which was meant to be established in 2016, was then completed and published. Page 27 of that document states, we'll continue to make it a priority to protect first-line responders through ensuring that they are equipped and trained properly. We will continue to ensure that we have the appropriate stockpiles of medical countermeasures to address crises, and that these are resilient in our supply chains for key medical countermeasures. This mantra of claiming that we were sufficiently provisioned with PPE and stockpiles was being repeated right up until March 2019. Just go back a little bit. On the 11th of February, Steve Oldfield, the Chief Commercial Officer at the Department of Health and Social Care, was reassuring NHS staff that NHS and wider health systems are extremely well prepared for these type of outbreaks. On the 18th of February, just a week later, there was an NHS briefing paper titled Primary Care Providers and the Coronavirus, and that stated that the NHS and Public Health England were well prepared for outbreaks of new infectious diseases. And in response to the question, are there supply issues with PPE? The briefing states that there was a large stockpile of face masks in the UK managed by PHE as part of pandemic influenza preparedness stockpiles. The NHS supply chain had placed additional orders for PPE and was working with wholesalers to support frontline services. NHS supply chains also retained, apparently, an EU exit stockpile, which included stocks of PPE. 17th of March, NHS officials told the Common Health Select Committee that the supply of PPE in the UK was adequate to keep staff safe in the months ahead and insisted that existing top stockpiles were sufficient. Now, these stocks and contingency plans were obviously inadequate. We found that there were shortages of scrubs reported by more than 32% of doctors, shortages of long-sleeve disposable gowns by 30% of doctors, and no supply at all of disposable goggles were reported by 11% of doctors. By April, it was clear that staff were not being kept safe and the supplies were not adequate. In response to that, Professor Ian Boyd, who advised the Environment Department for 7 years and was involved in the writing of the 2018 biosecurity strategy said that a lack of resources were to blame, and other experts said that there was a gap between action, planning, and the actual strategy had entirely stalled. Moving on to May 2020, we learned that 80% of the respirators in the national pandemic stockpile were out of date when the coronavirus hit the UK. 200 million pieces of kit, respirators, masks, syringes had all expired in the 8 months before January of this year. And this included 20.9 million out-of-date respirators out of a total of 26 million. More than half of the stockpile of surgical masks had also expired, some of which has expired 7 years before their use-by date, i.e. 2 years before the original David Cameron report. The result of this was that 20% of hospital patients caught with COVID had actually caught COVID in the hospital. Now, this was not particularly surprising when, if a human being is infected by a respiratory disease and doesn't have PPE, well, they become an agent of infection rather than an agent of help. We also find that as of July 2020, a total of 625 healthcare workers had died, unfortunately, due to COVID-19. During that period, they had a severely short supply of PPE. The ventilator issue was identified in Operation Cygnus itself in the exercise, that there was a lack of ventilators, and the DHSC sought to boost these ventilator numbers by buying on the international market, expanding the NHS's existing oxygen and ventilation program, and announcing the ventilator challenge, this being a challenge to industry and business to quickly bring to market thousands of ventilators. At that time, at the beginning of the pandemic, we have 8,000 ventilators available to the NHS, 5,000 initial UK government requests for extra ventilators were made in March, and 30,000 was the subsequent target to be reached with the help of the ventilator challenge. However, the challenge being an invitation to industry to come up with a simple design for mass production, and UK medical safety regulators were by March warning that at the height of the first wave, a drive to build thousands of basic ventilators risked wasting resources and delivering worse patient outcomes. The regulator reported the panel's concerns that rudimentary ventilators could in fact harm patients. Now, this program, we spent about 200 million on the challenge out of an allocated budget of 454 million. The orders were placed in May for 10,000 Dyson Covent machines, and according to James Dyson, 20 million of the taxpayers' money was spent at the start of the program. Ultimately, none of the basic ventilator challenge machines were approved for use, or required indeed, since the NHS was able to meet demand without them. And Alison Pitters, the Dean of the Faculty of Intensive Care Medicine, said that the machines were of no use whatsoever. So the ventilator challenge involved the pursuit of domestically produced devices to plug shortages, but the devices themselves were deemed unsafe. I think at that point, that is the setting for the issues to do with PPE and ventilators, and I hope to hand over to those who are experts in the field to plug in any of the gaps.
Well, Tasmin, thank you very much indeed. You've given us a magnificently forensic and detailed account of what happened, where we got to, and how. But I'd now like to sort of, from that really splendid start, dive in to talk to some practitioners and campaigners about what their thoughts are about the failures, the successes, and something in between. Beginning with Dr. Rachel Clark, who's a very well-known palliative care doctor, has a book coming out called Breathtaking in the new era, but I believe, about what we've been going through, and her work during the pandemic, which is a book one is looking forward to, and is also a slightly humbling person for a journalist to speak to, since she used to be a journalist but is now a doctor, which kind of holds one in slight shame. Rachel, thank you so much for joining us. I guess I wanted to go back to something that Tasneem alluded to explicitly, which was actually without naming her, which was that Amanda Pritchard, the Chief Operating Officer of NHS England at the Health and Social Care Select Committee on March 17th, said, we have the adequate supply we need, which was really, less than a week before lockdown, right on the verge of the pandemic becoming a massive collective moment, and inadvertently or otherwise entirely misleading. You were involved on the front line. First of all, were you aware of that having been said, and what was your professional response to that? I mean, were you aware that it was as wrong as it turned out to be?
Absolutely, I was aware of it at the time, and in fact, there were lots of official senior figures in public around that time saying, we absolutely do have all of the PPE we need. If there are any problems at all, they're just around distribution and we'll sort these out. And I knew from my own first-hand frontline experience, but also from the testimony that was pouring into me from other frontline doctors and nurses all over the country, because I'm very active on social media and the mainstream media, so people tell me what's going on because they want to get that testimony out there. I knew that wasn't the case. First of all, so I worked in the first wave in two settings: a hospital setting, acute hospital setting, and also a hospice setting. And that's very interesting because hospices, in terms of obtaining PPE, are counted as ranking as the same as care homes. And we all will remember what was being described in March and early April from care homes. We heard of carers who were having to use homemade PPE, they were using bin bags and so on. And my hospice testimony absolutely bears out the truth of that. I can state on the record that in very early April, so when we were approaching the peak of our COVID figures, my hospice came within 24 hours of having to close its doors, by which I mean we would have had to evict all of our patients, many of whom were very close to death. They were literally actively dying. We would have had to have sent them to our local accident and emergency, which was of course filled with COVID patients, and close our doors because we literally didn't have the PPE we needed to carry on safely. So the hospice management were put in a situation either of knowing that their staff were at risk of catching COVID because we had not been given the right PPE by the NHS supply chain, or we would have to send all our dying patients away. And both of those were just intolerable. The week when that happened, there was a 24/7 NHS PPE hotline that was much lauded by the Health Secretary, Matt Hancock, at the time. He talked about it as though it was this wonderful panacea for any PPE problems people were having. And we called that hotline, which was meant to be a 24/7 service for crises just like ours, over and over again. And in the end, we're told, my medical director was told by the person on the end of the line, I've heard what you've said. You're telling me you're going to have to close your hospice tomorrow and send away all of your inpatients because you do not have enough paper masks to carry on safely. But no, we can't help you. There's nothing we can do. He gave a Department of Health number and said, you can try that. We called the number and there was no answer. And the only reason our hospice didn't close was because I begged charity contacts I had, and we managed overnight to obtain the masks we needed to stay open safely. We also had to beg local veterinary practices, businesses, schools, anyone we could find to supply us with PPE, because we did not get it from the NHS supply chain. And I know for a fact that our situation was replicated in hospices in other parts of the country, because we were all talking to each other. We were appealing on social media for PPE to stay open. And all of that happened because hospices were on a par with care homes. So those kinds of crises were happening in care homes as well, up and down the country. The PPE was not there, and it was catastrophically bad. In terms of hospital PPE, I was very, very lucky in my hospital. We did have good supplies of PPE, mercifully, and I don't know of any instances where people were having to use homemade PPE, for instance. But I think it's worth pointing out that around the time you're talking about the 17th of March, just before that, the official government Public Health England guidance for what levels of PPE were appropriate in different clinical settings were abruptly changed. So in early March, everybody seeing patients with suspected COVID was wearing level 2 PPE with proper, the best FFP3 masks and proper long surgical gowns. And abruptly, the guidance changed to say the majority of frontline staff only needed to wear level 1 PPE, which was only a paper mask and a skimpy plastic apron, a pinny rather than a full gown. That happened with no warning whatsoever or scientific justification to frontline staff. So doctors were incredibly frightened because all of a sudden they went from a situation where one day they felt protected and the next they were wearing skimpy plastic pinnies and paper masks with no explanation. And I was deluged with testimony from people saying, we're all going to catch COVID. Why has this happened? And there was an attempt to say this change has happened because the science has changed, which was surprising because it wasn't clear where this new science was coming from. And also the new UK standards were lower than both the WHO standards for PPE and also the European standards for PPE. And we knew that the reason this downgrade had happened wasn't because the science had changed, it was because the size of the PPE stockpile was found wanting, and it didn't have the long, proper protective gowns that we felt we needed. And so that was a very, very frightening situation for frontline staff to find themselves in. So those are really, I think, the most important points I'd like to state from that period, both that this sudden downgrading in the absence of evidence, I would argue, but most fundamentally, although hospitals were better placed in the community for care homes and hospices and GP practices, it was absolutely catastrophic, the lack of PPE.
Isn't it the case, just sorry for my layman's ignorance, but isn't it the case that it was directly at odds with the direction of the science? Because what was happening at that stage was there was a greater awareness that all frontline staff, all people working in hospitals and hospices and the care homes needed fluid repellent gowns and visors, because this was, this was a disease that was airborne, and that it needed that kind of stronger PPE rather than the flimsier forms that you're referring to.
Yeah, so I think at the time that wasn't entirely clear. And Professor Montgomery will probably be able to answer this with more detail, but the WHO in March, it wasn't at all convinced that this was a truly airborne disease. That the fear was that infection hinged fundamentally on aerosols, so aerosol generating procedures, which produce tiny little droplets containing the virus, were the most dangerous, and hence the highest levels of PPE were limited to those staff who were around aerosol generating procedures. So that was the official argument. However, the WHO advised visors for everybody and also long fluid repellent gowns for everybody, precisely to minimize the risk, because the science just wasn't clear at that stage. Somehow, the government stroke Public Health England decided that visors for everybody and long gowns for everybody was not necessary. And I would love to know the basis for that. The argument was that in Britain, we have a bare below the elbows policies, and it's actually better not to wear long gowns. It's better to just roll your sleeves up and have bare forearms. But I was getting messages from people who were working on COVID wards, infectious diseases consultants in more than one hospital saying, I know that we are going out of our ward in our scrubs now, and we are going through different parts of the hospital into the canteen, etc. And we cannot guarantee that our scrubs are not covered in COVID, because when you wear an apron, all of this part of you, so your neck and the top of your chest is not covered properly, the bottom of your legs isn't covered, your back isn't covered, whereas in a surgical gown, all those parts of you are covered. So when you take it off, your scrubs should not be coated in COVID. So there was this desperate anxiety amongst many doctors I spoke to that they were vectors. They were taking the virus from their hotspots into other parts of the hospital. And of course, subsequent evidence suggests that's exactly what has happened, that a proportion of hospital infections have been driven by staff themselves inadvertently, unintentionally spreading them. So it was a real concern.
Thank you very much, Rachel. I'd like to turn now to Hugh Montgomery, who's Chair of Intensive Care Medicine at UCL, amongst many other distinctions. Hugh, I wonder, just sort of going back to that that sort of moment, the time frame of realization. Had you had any intuition that the pandemic preparedness was, as in terms of PPE, was as poor as it turned out to be? That the gap between, as it were, claim and reality was so vast?
No, but I think it's probably worth putting this in context. So for those of you that don't know my background, I was working in frontline intensive care during COVID wave 1, but also had some national roles in trying to glue together what the disease was and how we should manage it, sort of the knowledge sharing and so forth. So I think it is worth putting in context that the first witness we heard from there was talking indeed that preparedness was for pandemic flu. And I think if there's a flaw in retrospect, that was probably one of them, because this disease is not like flu. It really isn't. This is so far from being simple flu, and that wrong-footed people. So I think the preparation was there for a flu-like illness, and we all know what flu-like illnesses do. And we also know what they do to people with bad lungs and how to ventilate them. And in fact, it's not terribly difficult to ventilate simple flu lungs. So the preparedness for that is very different from the sort of disease we then saw here, which is a multi-system disease affecting 7-8 systems at once in critically ill patients that require very sophisticated ventilation and so forth. The second thing was the infectivity is not the same as flu. So normal seasonal flu has an R value of maybe 1.2-ish. The R value, as we know, depending on social involvement and the K numbers, when this pandemic came out, was well above 3. So this is a very, very much more infectious disease, which in some people caused very, very much more complicated disease. And the burden that tracked through to intensive care was very much greater than perhaps had been planned for. So we were wrong-footed with that. I think we were also wrong-footed because we didn't really know, as Rachel pointed out, how this disease was being spread. And in fact, whilst it was mainly considered to be droplet spread, so these are more than 5 micron diameter watery particles that basically gravitate out or impact within 2 meters in general of exhaled breath. And there were some case reports beginning to appear, particularly some tracking of bus passengers in Wuhan, suggesting that there might be a degree of aerosol spread, although the burden was considered largely to be droplet. But given the uncertainty about the R number, how it was spread, the degree of infectivity, and the impacts that we were seeing, which were not like flu, and this really gravid impact on critically ill people, the PP that got deployed seems to me, and I have no evidence for this, to have been pulled out of really what we might call the Ebola Playbook. And again, our first witness referred to that. You know, we'd had experience of in Sierra Leone. But Ebola is a very different disease, and it's transmitted very differently. It transmits, you can get it through skin, cuts and so forth. And therefore long sleeve water repellent gowns for that sort of disease are important. It turns out they're not important for protecting you against this disease. And in fact, the overkill was part of the problem here. People were desperately worried about spreading this disease and the fact that it could be rapidly fatal. And as Rachel points out, healthcare workers were terrified, as were patients. And this led to mass use of rubber gloves, which it turns out we don't need, and in fact probably contributed to spreading the disease. Long sleeve water repellent gowns, which we don't need really, because there's no need for them to be water repellent. And with that, this constant churn, because we didn't lock down early enough. The WHO playbook was very clear for pandemics. You lock down really hard and you lock down really early to keep your numbers down. When you've got a very highly contagious disease and you let it get grip, you end up with the tsunami we got in wave 1, with massive numbers of patients hitting hospitals. And then this constant churn, because it's not just one pair of rubber gloves people are putting on. You put them on, deal with the patient, take them off, put another pair on. And the same with the water repellent gowns, which, as you say, largely to a degree weren't needed. The problem then came, of course, also with communication. Rachel's absolutely right. I mean, it's been a failure throughout this pandemic, in my view. The clarity of the communication to everybody, healthcare workers and to the general public. And if things had been explained clearly, there would have been a great deal less panic. And indeed, when we moved on our ITU away from this burdensome protection to much simpler forms of protection, we just did a very simple video with an ex-professor of infection prevention control to explain it, get an all-hands Zoom meeting, and it was adopted immediately without a wrinkle. No one was concerned because it had just been clearly explained over a few minutes. And that's so important. If it had happened, we would have had a lot less worry, I think. And the final bit, of course, about this, which is relevant too, is about the supply chains. And again, I'm not being an apologist for this government, nor do I have inside information. But flu, seasonal flu, when it breaks out, rolls seasonally. That's its nature. So we know many months ahead what hit Australia and which version it is, and we start getting our vaccine prepared for the season that hits us. This was a global pandemic that hit everybody at once, that was in no way seasonal. And this was a big problem because everyone wanted the PPE and ventilators and anything else they can get hands on at exactly the same time in every country in the world. And every country was locking down, so the manufacturing capacity plummeted everywhere. And I'm not sure that that double whammy would have been anticipated when the focus was on a nasty flu, an H1N1 that got worse, for instance, which this was not.
But that raises a very interesting question, which is, was it merely capricious, or because we'd had H1N1 that we lit upon a flu as the likely pandemic, rather than looking at the experience of countries that had suffered from SARS? I mean, why light upon flu as what was going to happen if you are planning for a pandemic, rather than what happened?
Well, I don't know is a simple answer, because I suppose there'd been the experience of H1N1 and there'd been the Spanish flu, which was a bird flu 100 years earlier. But you're right, we'd had two spillover events, as they're known. So these are viruses that move from animal hosts into humans. And we've had, if you discount H1N1 being a bird flu, we had MERS and we had SARS-CoV-1, which we were blessed with, not a good thing in terms of very high case fatality, but blessed with very low infectivity, which meant that it didn't spread quite as readily. So I suppose that was probably the thinking, that flu had been a transmissible disease. We'd seen it before, it was coming again. But actually these coronaviruses, and there are 4 routine effectors that give us the sniffles and a bit of a common cold, tend not to do very much more than that, or at least in humans hadn't until now. And then this one bust out and caused this sort of problem. And it will have to change thinking. There are over 5,200 more of these coronaviruses out there. And as humans ingress into natural habitats at this alarming rate, because this really is an environmental crisis to a large degree. It's humans going where they shouldn't be in large numbers, destroying habitats, forcing animals closer together in fewer numbers so they predate where they wouldn't otherwise, with now mass transport of, before COVID, 150 people a second getting on an aeroplane. We've cooked up a recipe book for baking this crisis again and again and again coming down the line. And it could be a lot worse. And bear in mind, you're quite right, that we can't now go, well, it's either going to be flu or it's going to be a SARS-CoV-2 type thing that does the following. Because bear in mind, every day we were seeing something new with SARS-CoV-2, with COVID. We were ringing each other up going, I've seen 2 of these. Have you seen that happening as well? Oh my goodness, that seems to be a real thing. But there are other viruses out there in Brazil that cause encephalitic processes. There are, we can't, I think, make an assumption that what we've had in the past is what we're going to get in the future.
Thank you. I'd like to turn to Jolyon Morm now, who heads the Good Door Project and also has been intimately involved in chasing these questions. Jolyon, we enter now the question of, you know, having realised we didn't have the kit. How did we get it? How would we go about getting it? NHS Supply Chain Coordination Limited didn't seem to be particularly good at the task that it was given. Lord Dayton was brought in, the former Olympic chief, to kind of pep it up. At the very least, it would appear that there was a kind of improper haste in the way in which procurement was then gone about. What do you think went wrong and why in that phase?
Yeah, I mean, very good question. And of course, the NAO report that was released earlier this week is sort of part 1 of The Godfather. Part 2 of The Godfather is going to follow later this month, and we will read at least the NAO's views on all of those sort of early stage preparedness questions. I mean, it's interesting to look at what other countries did and how they got it right better than how we got it right. As I understand it, in Germany, the German government said, in effect, if you turn up at a warehouse with some PPE, we will buy it from you at a fixed price, so long as it's of an adequate quality, and you can bring as much as you like and we will buy it all. And that secured at least PPE which was of a good quality, and it also secures transparency over pricing, because you know, one of the lingering effects of the pandemic is going to be a real loss of trust in government, which has deleterious effects right across the political piece, really. I mean, there are at least 3 people on this panel better qualified than me to talk about health effects, but you know, the governance stuff is pretty alarming, I think. And you know, there are some huge unanswered questions, actually, ones that the media have yet to focus on. So for me, the most striking feature of it all is this: on government's own figures, we bought 32 billion items of PPE. We bought them all right at the top of the market. Prices were sometimes well over 1,000% higher than they'd been in sort of Q4 2019. And we have used, in the period from February to November, 6.8 billion items of PPE. And I don't understand, whatever other excuses one might feel inclined to make for this process, how it is that we ended up buying 5 years supply of PPE, how it is we ended up buying 5 years supply from these odd counterparties without proper competition. And as I say, at top of the market prices. And what we see now is that this stuff is, there's a great big NHS warehouse in Daventry where it's all supposed to be stored. It is full to the rafters. It doesn't actually have rafters, but you know, it's chocker. And then we've rented a whole bunch of warehouses elsewhere around the country, and they're also full. and the port in Folkestone, which is going to become quite important in 6 weeks' time or so, is also full. It's full of shipping containers, and it's so full of shipping containers that some of those shipping containers are being airlifted to fields around Suffolk. And indeed, so full is Folkestone and the fields around Suffolk that we are renting warehouses in China to store all of the PPE that we bought. And it gets worse, actually, because all of this stuff that we bought that's sitting in shipping containers is exposed to mildew risk, so we may never be able to use it, even if it is of a standard that is usable. And we can't check whether it is of a standard that can be used because it's in a shipping container, and we're losing our contractual right to sue these odd counterparties who supplied this PPE that is sitting in shipping containers and that we bought without any proper process at top of the market prices. I mean, the whole thing is, it defies rational explanation. And so, as I say, whatever other excuses one wants to make for government's handling of the process, I really struggle with this stuff.
No, absolutely. Wanted to turn now to James Kinross, who's a friend of Tortoise and more importantly, a hugely distinguished consultant director or surgeon at St Mary's. James, what is your view on do by all means chip in on any of the questions that have been raised already, but we haven't really discussed ventilators. And the question that strikes me on this is that it became a national undertaking very quickly to rush towards ventilators. All sorts of undertakings were made, consortiums formed, 569 million spent, 20,900 procured, and only 2,150 used. Now, was this an error of a genuine error of planning, or was it simply because our clinical knowledge of the virus was forgivably poorer at the start than it was a few months in?
First of all, thank you for your generous introduction. Flattery will get you everywhere. I certainly don't know if I'm hugely distinguished, but the answer to that question is not easy. And the answer is both of those things and more. And it's really about context. And to try and answer that question, I'm just going to take a step back because quite a lot has been said, and I just wanted to respond to a little bit of it. In terms of PPE, you need kind of four key things, right? And Hugh alluded to a lot of this. You need supply, which we did not have. You need, if you're performing aerosol generating procedures like I do and Hugh does, you need to be properly tested and to make sure it fit, which happened variably. You need to be educated and trained. And I know that was made in the opening statement, which we were not. And you need to have trust, which we did not have. So as soon as the PPE issues started to become a problem, because we didn't have those four things, it was very difficult to wrestle the initiative and to do what Hugh described and to communicate clearly. We didn't have evidence, and a lot of that evidence still doesn't really exist. I know that because we systematically appraised it, and others have systematically appraised it. And I point you to Trish Greenhouse's work on this. And a lot of it was based, exactly as Hugh said, on SARS and Ebola and other diseases that were not of the correct context. But clinical context is absolutely everything here, right? PPE is only as good as the system that it's working within. So as soon as the pandemic hit, and I was on call in the second week of March, and I witnessed this unfold, we thought, well, if no one else is going to educate us, we better take the initiative. And we set up an academic response to that called pansurge.org, and all of our data and all of our early webinars that we ran through March are all there for you to look at. And the first thing that we did was call up some Italians because they were 2 weeks ahead of us, and we knew that. And we ran a webinar on the 15th of March, and roughly 2,000 people watched that webinar live. And we asked them at the very end of that webinar, if you knew three things then what you know now, what would you tell us? Because we know this is coming. And they said, we're going to tell you three things. Number one is you must protect your staff at all costs. Number two is you must fear the COVID negative ward. There was this ridiculous phase at the beginning of the pandemic that there was a difference between a COVID negative and a COVID positive ward. We weren't testing anybody. We didn't know who was COVID positive or negative. We pretended we did. And the third thing that they said is you must maintain your elective practice. We did none of those three things. We wrote that up, we put it in the HSJ, we distributed it as far as we could, and there was a complete failure to respond. So unless you have a hospital or a social care setting that is set up with a process and a flow of patients through that process, through which that PPE can be effective, it fails, and it fails catastrophically. And the implications of that were dramatic for us. So I'm a surgeon, and you might argue, well, what good is a surgeon in a pandemic? Well, a surgeon is important because we still have patients with...
Oh, I think you're frozen there. Hopefully we'll get James back.
He was so into managing the initial response. We didn't have enough scrubs to wear to operate. At one point, I was told we didn't have enough gowns to have a trainee in the operating room with me because they physically couldn't wear one. So our ability to maintain other services in the hospital was directly affected. And then you get onto the subject of ventilators. And again, like Hugh really is the man to talk about this. So I wouldn't want to talk too much about it. But again, what I would say is that when this crisis happened, there was a rush to collaborate. Industry wanted to help. Everybody wanted to support the NHS, and that was fabulous. And there was a lot of good in the rush to try and manufacture and to generate ventilators. But ventilators are only any use, number one, if you've got clinicians to help run them and manage them and to nurse the patients that they are connected to. And I lost 30% of my staff within the first 3 or 4 weeks. It's questionable whether or not it's a really good idea to train a surgeon like me to run a ventilator, which was what was happening. So we were being given PowerPoint demonstrations on how to ventilate patients, which is not a good idea. You don't want me ventilating you. And the other thing is that, to answer your question, SARS it was different to COVID-19, and actually ventilating these patients it's hard, right? And there was a real question about actually whether ventilation was the right thing for these patients and whether or not actually we should have been giving them ventilatory support like CPAP or continuous positive airway pressure or other supportive measures before ventilating them because the mortality was so high when you ventilated them. And there was another question about whether or not, as you heard in the legal testimony at the beginning, these ventilators were ever going to be fit for purpose and how long it was really going to take to get a certified ventilator into the hospital to actually ventilate someone effectively. And that was questionable at the time.
How was it foreseeable, James, that CPAP would be as successful as it turned out to be?
I'm going to defer to Hugh on that question because I'm probably not really qualified to do it. But I have to say, what I would say was that it was incredibly distressing to see young people, and I say young now because I'm a bit older, in their 40s, or 50s, who had levels of oxygen in their blood, which you would normally panic and intubate over. And this was just normal. Our wards were absolutely full of them. I think from my respiratory colleagues, they certainly, wanting to put lots of people on CPAP is almost as hard in some ways as wanting to ventilate because you need space and room to do it and you also need the equipment to be able to do it. I'm not sure that we really understood that at the beginning in March and April as to whether or not CPAP was going to be as effective as it was. I would defer to Hugh for that question.
Thank you so much. I'd like to turn now if Joe Goodman's around from Families for Justice. Joe, are you there?
Hi, yes, I'm here.
Hi, Joe. Thanks so much for joining us. I wondered if you could talk a little about your own experience.
Yeah. So I'm one of the co-founders of COVID-19 Bereaved Families for Justice. We're a group of 2,000 individuals who are personally bereaved by COVID. I lost my dad on the 2nd of April. He was a cancer patient, just undergoing diagnosis. He also had a number of other health conditions, which unfortunately read pretty much like a checklist of vulnerabilities to COVID. We think he's most likely to have contracted COVID at a hospital appointment on the 18th of March, where, despite knowing that there was widespread community transmission, staff hadn't been provided with PPE, there were no protective measures put in place at all. And once we knew he'd contracted COVID, there was really not much that could be done other than make him as comfortable as possible, which we're hugely grateful that the medical team were able to do. And that we were able to see him, which not many families were able to do, particularly at that stage. Our group, one of the things that we wanted to bring into this discussion, because as you can imagine, within our group, there are a huge number of questions, a huge number of circumstances where people feel that their loved ones' deaths were avoidable. I particularly, we wanted to raise in this session the question as to, so clearly it was hugely challenging and continues to be challenging to provide care to people who come into the system. I suppose one of the areas that comes up very regularly within our group, and I think we've got Lee Morgan-Jones on the call as well, who hopefully will be able to share her dad's story, but is around whether people were actually able to access care. So quite quickly, when people began sharing stories, it became clear that people had huge issues with 111, telling people to stay at home when clearly their symptoms were really quite poor. We've since found out that the 111 service in response to COVID was actually run by different companies and didn't actually run through the normal 111 processes. And so many of the team fielding the calls were very minimally trained. And it appears we're almost following a very basic flowchart. Lots and lots of people in our group believe that the fact that their loved ones weren't admitted to hospital meant that it was too late for any treatment to happen when they made it to hospital. And also there were quite a few cases where people passed away at home. And our main emphasis really is to make sure that lessons are learned so that other people don't have to go through the same pain that we do. And just on a kind of a side note, I think the messaging, so you talked about patients in their 40s, I still think the messaging is that if you're not in a vulnerable category, then you just have to sit it out. And I actually became aware last week that an acquaintance of mine was very seriously unwell, but didn't think they needed to go to hospital or seek medical attention because they didn't consider themselves vulnerable. When I heard about their symptoms, I told them that they probably did need medical attention, and they ended up being admitted and they very much needed to be in hospital. So that's a few different things, but I'd be really interested in the medical professionals' views on this as well.
Just before that, Jo, I mean, thank you so much for sharing that with us, and you know, condolences for, you know, such an unspeakable loss. I'm so sorry. Was it your impression during what must have been a horrendous experience that what was snarling the system up was a lack of preparedness, that the system that had been better prepared could actually have saved more lives?
Absolutely, and I think the more information that comes to light, the more it seems that everything was a last-minute scramble. So, you know, the fact that vulnerable patients were being seen when my dad was, and I think the kind of issues with hospital-acquired COVID have actually been quite underreported. Within our group, it appears that potentially that was, you know, almost as high as care home transmission potentially. And the fact that staff hadn't been provided with PPE, there were no kind of instructions to treat people differently, you know, no ventilation. Actually, the appointment my dad went in for could have been done over the phone potentially, and there was no treatment, no diagnosis. Similarly, with the 111 service, knowing that this was coming and potentially there was going to be strain on the service, surely there should have been time to train up additional staff rather than bringing people on board that were totally unprepared. And from what I can make out, it was a hugely distressing experience for people who were fielding those calls. And we don't know whether any of that has improved, because the government hasn't engaged with us around any of our concerns, and there's really been minimal possibility to kind of feed in those experiences to try to ensure that the system is improved.
Well, thank you very much for helping us, Jo. Can we go to Lee Morgan-Jones now? Lee, I'm not sure if you're there. Hi, Lee. Hi, thanks very much for joining us. I know you two are associated with the same organisation as Jo. Can you give us an idea of your own experience?
Yeah, sure. Thank you for the opportunity. And it is focused very much on mine and probably about 25% of those 2,000 members of our group who have very, very strong concerns around the 111 service. So what happened with my dad, and this is Dad, this is Ivor Morgan, 75 when he passed, living with Mum, very active. They were away on holiday in Spain at the time, came back. They were both poorly for a few days, but they soon got over it, didn't think much of it. They were in Spain during the Spanish lockdown, unfortunately, so they didn't have much of a holiday. So they came back, and within about a week, we went into our national lockdown towards the end of March. And around the 24th of March, Dad became ill again, Mum didn't. But this illness was different. This illness was very concerning. He spoke very strongly when you were having a conversation with him, but his normal behaviour, how lethargic he was getting a little confused at times. There wasn't much of a cough, but we did think it was probably, unfortunately, COVID. Mum rang 111 as we were being told to do by the government, and they said to her, "Can you ring back on day 8 of his symptoms, please?" Mum was a little frustrated, but she did what she was told to do and had trust in that advice. Anyway, they had worked out for his current symptoms that was day 6, so 2 days later would have been day 8. Those 2 days were rather distressing. Dad was okay, but he wasn't the Dad that we knew. He'd had several collapsed-in sessions, but would recover quite quickly. Mum tried to keep him in his bed as much. He only managed a couple of spoonfuls of soup. And on day 8, she rang back as instructed. At that point, a doctor came on the line and asked Mum if she could take Dad's blood pressure, which was done. Mum did have that equipment at home, luckily, and the doctor agreed with Mum that his blood pressure was very, very low, but that he should be okay. That's a direct quote. So Mum, who at the time was 79 herself, but very active. I don't want to paint a picture of a member of the public or a couple within the public that weren't capable. Quite the opposite, amazing for their ages. So she did what she was told, but later on that day, Dad is walking upstairs back to bed after, funnily enough, those few spoonfuls of soup, and he collapsed backwards. He hit his head, and his head split open. Mum immediately rings 111 again, and they agreed that an ambulance was needed at this time. The ambulance turned up. The paramedic said to Dad, "Do you want to go to hospital, Mr. Morgan?" And Dad responded, "Only if I have to." Mum started to insist that she thought he really did need to go to hospital, and they agreed that a nurse would come to the home, our home, to stitch Dad's head up in situ in the home. There was still a huge reluctance to take him to hospital. I understand why from the health service perspective, but obviously I find that really hard to accept from a human perspective of that being my dad and needing care. The nurse arrives, and the nurse took one look at Dad, didn't even bother stitching him up, and said, "This man needs to go to hospital, and he needs to go to hospital now." Dad was taken to hospital. He rang us himself off his mobile. Mum had packed a bag ready for this to happen anyway. And he rang us and he said, "Jackie," that's Mum's name, I'm now going to go into ICU. And Mum says, "Okay, my darling, I love you. We'll see you soon." And my dad died 30 hours later from being taken into ICU in the Royal Gwent Hospital, who I have to say were angels. I have no concern over what they did for my dad. They kept in contact with both me and my mum, and they enabled me to have the last 9.5 minutes of my dad's life to talk to him and listen to the machine slowly dying down. And they gathered like angels round his bed, and I tried to do what I could. Mum wasn't up to it at this point. So the impact of all that was that Dad was a very popular guy. He was still working. He was doing volunteer work. He was the chairman of a club, and his life was full. And we knew that when the day came, we were going to have to perhaps dig into some savings to give him a really good send-off. Instead of that, there was 3 of us. It was in Wales. We were allowed 5 by the Welsh government, but Mum couldn't choose the other 2. So there was me, Mum, and my husband, Darren. Mum still blames herself. That's a massive impact. Mum still blames herself for not kicking up more of a fuss about it. Mum has had to move from the family home in Wales to be closer to me because I couldn't give up work, and I live in Staffordshire, and I enjoy my job, and we decided as a family that it was probably better for Mum to relocate to me. Mum's relocated. That has had a small financial impact on the family, which is fine because I'm really pleased with where she is, but the rate of where she is homed to the rate of the selling of the 4-bedroom detached house is an extra 50% cost on top. Not that I'm complaining about the money, but I was asked to share the impact of this. You cannot escape from it. It is there in every waking hour. Even sat here now, I've brought stuff from work and I've made sure that I've cleaned everything before it came in the house. When I love current affairs, it's all over the news, listening to all you amazing experts. It's been really upsetting to hear, but I thank you for your honesty and your straightforwardness. There are other themes as well from the group around test and trace, hospital-acquired COVID, not just the 111, obviously the PPE, there's the BAME community that is a massive theme within the group, and we can't even get the government to speak direct to us. So I thank you for today, and if you could include the 111 in your findings and to get the front line of where the public are told to go to get that threshold criteria correct, I would be very grateful. Thank you.
Well, no, the thanks are from us to you, Lee, for your courage in sharing that trauma with us, and it really acts as a very powerful reminder that the heart of all this medicine and policy and political discussion lies, very, very real human suffering, and the purpose of all this is to perhaps learn lessons that may prevent this happening again. We are running over time, which means unfortunately I'm not going to be able to go back to people as I had hoped. There is so much content here. Can I just return briefly to Tasneem, just if there was anything you wanted to interject at the end of the session, in case taking in what you've heard, might sort of bookend it.
No, I'm very grateful. I think all our experts have demonstrated that they've had to work outside of their actual expertise to do the basics of communication. Now, where our experts are medical doctors and are professional in terms of looking after their patients, we expect our politicians maybe to be experts in communication at the very least, if not prioritization and organization. And if the question is, did they fail in that, then I think the answer has to be that certainly with communication, organization, and prioritization, it would be failures in all counts.
Thank you very much. Well, I'm just before I close, and obviously warmest thanks to Rachel, Dolian, Hugh, and James for giving up their valuable time. My brief reflections are that I think what we see here is a centralized state that had decided, as Hugh pointed out that this was a pandemic that was likely to be a flu rather than SARS or a MERS, and that has had serious implications. That there was an overclaiming of readiness to the point where Rachel's hospice came within 24 hours of closure, and one found again another gap in as James alluded to in the nonsense of the COVID negative ward. As for procurement, as Jolyon said, it was, charitably at best a shambles, and perhaps we shall discover much worse. And that this created in the early stages of the pandemic a kind of crisis where, as James said, there was an absence of supply, of training, and of trust, all of which contributed to a very, very difficult early period in the pandemic, for which we are still paying a price, none more so than Joe and Lee. And I think it was fitting that the session kind of concluded with their testimonies, which was such a powerful reminder of why we're all here, and why this has been such a disaster, and one that we must not allow to slip out of memory, and from which we must learn the right lessons. We're going to break now for just over an hour. After lunch, my colleague and fellow editor and partner Kerry Thomas will be back to discuss the question of care homes. For now, thank you all very much indeed. Thank you to our experts. Thank you to all of you, and have a good break, and see you after lunch. Bye for now.